Welcome, everyone, to the PPMD and Duchenne Connect webinar series. My name is Ann Martin, and I'll be moderating today. I'm a genetic counselor with PPMD and the coordinator of the Duchenne Connect registry. So you should all be able to see the webinar slides on your screen, as well as a chat box for questions. So please feel free to send questions throughout the webinar, and we will try to address them as we go along or at the end of the webinar. And whatever questions we don't have time to answer today, we will provide you with an answer by email within the next week or so. So the topic for our webinar today is MD STARnet. MD STARnet is the Muscular Dystrophy Surveillance, Tracking, and Research Network. It is funded by the Centers for Disease Control and Prevention, and it was made possible by the MD CARE Act. And for those of you who aren't familiar with the MD CARE Act, it is the Muscular Dystrophy Community Assistance, Research, and Education Amendments of 2001. And MD STARnet would not have happened without the advocacy efforts of the Duchenne community, who demanded the need for critical data gathering in order to move research forward. So today we are very fortunate to have Dr. Dennis Matthews with us. Dr. Matthews is the Colorado co-PI for MD STARnet. He is a professor and chairman at the Department of Rehabilitation Medicine at the University of Colorado School of Medicine in Denver, and he is also a chair in pediatric rehabilitation medicine at Children's Hospital Colorado. So, Dr. Matthews, I'll turn it over to you now.
Thank you very much. Personally and on behalf of MD STARnet, I'd like to express my appreciation and gratitude to PPMD for allowing us to present our data. I'd particularly also like to thank Natalie Street and the staff at the Centers for Disease Control in helping me prepare this talk. So this was a very exciting opportunity for us as clinicians of neuromuscular disease to have the opportunity to come together with the epidemiologists within each of our variety of states to create this network. So today I'd like to spend a little bit of time talking to you about the process, what happened, and then get into more of the specifics. And as Ann said, please feel free to ask any questions at any time. So this was a very exciting adventure to start off with, and as you can see, the road was somewhat bumpy at times, but actually it was a most amazing process to participate in. So today I'd like to talk about a little bit what MD STARnet is, what the purpose of the program was, how many people are included, what we've learned so far, and what some of the exciting things that you can expect from the research and what's going to happen in the future. So MD STARnet is the Muscular Dystrophy Surveillance, Tracking, and Research Network. As you have heard, it's funded by the Centers for Disease Control and Prevention, and it was originally designed to study Duchenne and Becker muscular dystrophy. We would also at this point like to again thank Pat Furlong and PPMD for helping with the advocacy and development of the MD CARE Act, which, as Ann said, allowed this program to go forward. And then recently, this year, it was expanded to include 7 other types of muscular dystrophy. So MD STARnet is a data collection and research, and currently it's underway in Arizona, Colorado, Iowa, Georgia, and Western New York. The goals of MD STARnet were to determine how many people are living with Becker Duchenne muscular dystrophy within these states, to describe the health status of describe the health status of the people with Becker Duchenne muscular dystrophy and the healthcare services that they receive, to determine the needs, quality of life, and transition experience of people with Becker muscular dystrophy, and their families, and to provide this information to healthcare workers, to providers, to public health practitioners, policymakers, and teachers, families, and organizations like PPMD. So the data that was collected from clinics and hospital records throughout those 5 states. The data was accumulated from birth and death certificates, from hospital discharges. In one state, it was through the Medicaid system. And then as part of that, we've also then supplemented the information through interviews and surveys, and particularly most recently with adult males with Becker-Duchenne muscular dystrophy and their caregivers. The information that's been collected is extensive. It includes age, race, ethnicity, family history, early signs and symptoms, diagnostic information, information about clinical care, including cardiac and pulmonary information, hospitalization and procedures, mobility and rehabilitation issues. And as you can see, through 1998 and 2011, there were 925 people diagnosed with Becker-Duchenne muscular dystrophy. You can see the distribution. Arizona has 218, Colorado 201, Georgia 242, Hawaii, which was part of the group for a short period of time, was 18, Iowa at 129, and Western New York at 117. So these patients were identified using clinical signs and symptoms plus a variety of confirmatory evaluations and diagnostic tests. So they had an elevated CK or a family history. They had confirmatory testing on muscle biopsy or genetic testing, and quite frequently they had elevated CK, a family history that included diagnostic abnormal muscle biopsy or genetic information. So this was the first time that a prevalence study had really been done, counting all the people with Becker-Duchenne muscular dystrophy within the geographic areas of the United States. This allowed us to establish a prevalency of 1.3 to 1.8 people per 1,000 in those 4 states. In addition, we were able to determine that 90% of those 15 years or older were using wheelchairs. We found that nearly 60% of the males born between 1983 and 1987 were continuing to survive through 2007, and hence the need for us to emphasize the need for programs that address transition from child into adulthood. There was a question from Ivy about how complete is the MD STARnet. We're very comfortable that we've identified all the boys and manifesting females within those states, that we are very comfortable that we've identified all of the patients within that system.
Dennis, I did have a question for you as well. Is there any plans to increase the number of states involved, or will it stay the 5 that are included now?
I think right now the plan is to continue the 5 that are included right now. I think it would require some new authorization and funding, but we can ask our friends at the Centers for Disease Control to comment on that.
Okay.
So we took particularly interest early in trying to figure out the diagnostic testing and what was being happened around the country, and at least in the 5 states that are representative. And we looked at the documentation over time. As you has been experienced through most of the country, you can see that the diagnosis is significantly changed from moving away from muscle biopsies now towards the genetic testing. And with this, we know that the genetic testing improves and gives people a much more specific diagnosis and much more specific information about their mutation. This is important because this will significantly impact people and families' participation in clinical trials and enables other family members to be tested. So through 2011, we looked at the boys born between 1982 and 2004, and we identified that actually 73% of them have been the genetic mutation has been identified, and you can see that 78% are deletion, 11% is duplication, and about 10% is a point mutation. If you compare this with the other reported series, you can see that by increasing the number of patients, you see that the statistics change, and so there probably is a less incidence of point mutation than was previously described, and a little bit higher increase in deletion. We looked at then the documentation of the timeline between the diagnosis and clinical signs and symptoms, and we determined that the average age of diagnosis for the boys was about 5 years. Interestingly, the average delay was about 2.5 years between the onset of symptoms and the definitive diagnosis. And as part of the program that as part of our analysis, we felt that it would be important to recommend that consideration of adding a CK to the standard evaluation for developmental delays would be done by pediatricians and family practitioners. Sorry, it's a little blurry, but you can see in the diagnostics that the early signs and symptoms were noted at 2.5. The boys first saw their first health specialist at 3.6. The first neuromuscular clinic visit was at 4.6 years, and you can see the definitive diagnosis. First CK was 4.7, and the definitive diagnosis was at 4.9. And so this again shows us the consideration of if we see some symptomatology for suggestive of neuromuscular disease, a CK should be entertained. A little bit small, but you can see this actually breaks it into age groups when the first signs and symptoms are noted. And you can see we looked at less than 1.5, less than 3, 3 to 5, and less than 5. And so there are a number of interesting things that you see. In the 111 boys that are in this particular component of the evaluation, you can see that 58% of the boys less than 1.5 had some symptoms of gross motor delays. They had some muscle weakness. They had trouble walking or running. And interestingly, as you can see, there was a fairly significant proportion had some of speech and articulation delays. And so again, this has spurred us to recommend that, again, in the boys somewhere between 1 and 3, if we see gross motor delays, some difficulties with running or walking, and speech and language delays, that we'd certainly recommend a CK and a pursuit of the diagnosis as part of that process. Interestingly, we also then went back and looked at and see, are there other socioeconomic or demographic factors that were related to the delay in diagnosis. And we found that in the Black and Hispanic race, there was an association of older ages at initial diagnosis, initial CK measurement, and DNA testing. A positive family history was associated with a younger age at evaluation and testing, and a higher neighborhood of poverty was associated actually with the younger age of evaluation. During this, the care guidelines came out about corticosteroids, and so again we thought that it would be important to look at and evaluate what the presence or what the incidence of use of corticosteroids were prior to the recommendation for as part of the care guidelines. So we looked and saw that corticosteroid use had actually increased from 1991 from 21% to 44%, and that there continue to be substantial increases in cortical use across the MD STARnet states from 14% up to 49%. We looked at a variety of states, and you can see the red line constitutes the total of boys, so you can see they moved up over a period of time from 1991 from about 20% to 45%, but you can see the state-by-state variation, and we actually even looked at clinic-by-clinic that was de-identified so that we could try and see and tease this out. And we learned a number of important things by doing this. We realized that the clinics had a variety of practices in prescribing steroids, that clinics changed over time, and that we supported the guidelines, the recommendation that physicians offer corticosteroids to the patients. You can see specifically, if you look at the proportion of boys with muscular dystrophy on steroids, you can see the variety by a variety of clinics. And so you can see the clinic variation within these states, where one clinic is less than 10% and the other clinic is at 80%. So you can see a tremendous variation, and we're very pleased that the guidelines have come out and are making some specific recommendations. To show you the depth of the material that we have, I thought I would share a little bit of just the Colorado data that we've been spending some extra time trying to evaluate and look at. So we looked at specific procedures and services that were provided to the 156 people with Becker-Duchenne muscular dystrophy in our area. We looked at a variety of different things, and so you can see that 82% of those 17 and older had a cough assist machine. You can see that about half of the people were on BiPAP by age 17. You can see that scoliosis X-rays were the most common radiological service that was provided or used for the boys with muscular dystrophy. And interestingly, you can see that 72% of the boys had surgery by age 17. We looked at a variety of different procedures, and I think I've highlighted a few of those that we've already seen. You can see that by age 17, a significant number of the boys had cough machines. You can see a very high percent by age 17 are on BiPAP or positive pressure airway or continuous positive pressure. You can see the combination of continuous plus BiPAP is at 72%. We did have, like I said, a very high number of boys boys have scoliosis surgery, and you can see a fairly significant number having both tendon releases and gastrostomy tubes. And so we're again trying to further delineate some of these activities. We tried to look at the educational experiences, and we see that 82% of the boys in Colorado are in mainstream schooling, elementary through high school. The highest percent receiving special ed were during their elementary schools. We can see that the use of an aid has increased from 16% in elementary school to 37% in high school. And this is a very encouraging number. 69% of those 18 and over are attending college or post-secondary vocational school, which again significantly highlights the need for transition and appropriate vocational training. This is a very busy slide, but you can see this gives specific data that talks about school programming, home programming, whether they're in adaptive physical education programs, what percent of the boys have an IEP, whether they have aides at school, whether they participate in an early intervention program, and then again looking at what percentage are attending college or some kind of post-vocational. And so again, a tremendous amount of data that's continuing to be evaluated by a variety of the investigators within the MD STARnet. To also give you a little flavor of what's happening with our interview, we interviewed caregivers, the family, the parents that are providing, or family members that are providing care to the boys. And one of the areas that has been very exciting to look at was the incidence of complementary and alternative medicine. It's a very large, diverse group of medical and healthcare practices. It's not considered conventional therapy, but it's often used in conjunction with conventional therapy. And we thought that it would be important to look at, in addition to all the other care needs, whether families were using complementary and alternative medicine. And yes, we found that there was a significant increase, or significant use of complementary and alternative medicine in the families. You can see that there's a number looking at the biologically based alternatives. These are herbs, vitamins, particular supplemental dietary type activities. And so you can see the percent of families that have used those kind of activities. You can see the percent that have used massage and body-based, manipulative and body-based activities, including chiropractic and osteopathic. You can look at the mind-body group, which is aquatherapy, hippotherapy, hypnosis, prayer blessings, companion animals, and then look at whole systems looking at acupuncture and homeopathy. And again, you can see that there was a significant use. So we found that there were actually 80% of the caregivers that were interviewed report that their families have used complementary and alternative medicine, and you can see the percent that's used, of which the mind-body or the herbs or supplements have been the most common. We also found that the increase in complementary and alternative medications were used in association with the higher level education of the caregivers. So next I want to talk a little bit about, and each of those articles that I referenced have been published, and so we certainly can include that, and it's included in the bibliography. Someone asked me to show the this again. And do we have data on the kinds of diets and vitamins? We do. There is some variation by geographic area, and there is some difference, but there were so many varieties of different kinds of dietary supplements and vitamins that were used that we weren't able to tease it out. Each state can look state by state and have some available to look at what specific programs were used, but there was some variation by the state, and I'd be happy sometime if somebody wants to, we can try and look at more specific data state by state. So we also then did a transition questionnaire, because you can see, as I alluded to previously, a significant number of the young men are going to college and having post-secondary activities. They're doing more and more activity, and so we did a web-based survey of young men with Becker-Duchenne muscular dystrophy, age 16 and over. It was done in the spring and summer of this year in Arizona, Colorado, Georgia, Iowa, and the western United States, or western New York State, and to try to look at determining the experiences of males with transitioning from the pediatric to the adult care, to help determine what educational and employment opportunities they were, and to try and look at some independence, social participation, and quality of life. This is just in the middle of being analyzed, but we're starting to see that there is some quite interesting data, and we would hope that some of these publications would be coming out in the near future. We've looked at some recently published activity articles, and I've included a few of those just so that you can see. And if you go to the MD STARnet website, you can see all these activities or all these publications present. Recently was published an article about the reproductive patterns among males, among mothers with boys with muscular dystrophy. It describes the reproductive pattern of the mothers and examines the association of having additional children. And this was just recently published in the American Journal of Genetics, and I didn't have time to include all the specific information, but there's some articles there. We've submitted for publication an article looking at the patterns of growth with boys with Duchenne Becker muscular dystrophy. We have basically tried to simulate the growth curves, comparing the boys with the growth curves and comparing these. And these are the boys who were not on, did not receive corticosteroid medication. So this compares the growth patterns of boys without corticosteroids compared to their normal age-matched peers. And so this will give us a better opportunity to kind of look at and see specifically when we try to manage and help you manage the nutritional status of the boys, what the appropriate growth patterns are and what they look like. And so this has been submitted, and we would expect it to be published here in the next few months. As I alluded to previously, we had discussed the use of corticosteroids and the frequency by state and the frequency by clinics. We're now looking at the effect of oral corticosteroids on the delay of cardiomyopathy, and so there's a group that's looking at specifically describing what's the age of the boys who develop cardiomyopathy, and then trying to assess what the effect of corticosteroids are on the either the onset of cardiomyopathy or the severity of the cardiomyopathy. And so, again, this is another article that we would expect to be published soon, and as soon as it's published, we'll have it available on the website. As you are all aware, corticosteroids do have some risk factor, and so we've been trying to determine what the risk factor is, particularly with fracture. And so, again, another paper that's submitted for publication, trying to look at the occurrence of fracture and determine what the specific risk factors are for an increased incidence of fracture. And the risk factors that we've identified at this point are those that are full-time or part-time wheelchair users, those that are on steroids, those that are getting calcium or vitamin D, and then the group that's used with bisphosphonates. To go back, I have a question from Jennifer Hernandez that was asking about cardiomyopathy with MRI versus echo. There's some state-to-state and clinic-to-clinic variation. The vast majority of the patients who have been diagnosed with cardiomyopathy has been on echocardiography. It's only been recently that some people have been using MRI to look at cardiomyopathy, and so but the vast majority of the boys, the diagnosis was made by echocardiography. The group from Arizona was interested in looking at what the clinical features look like in siblings with Becker-Duchenne dystrophy. They were trying to look at and identifying when the brothers reached the selected milestones and determine at what age the older brother reached clinical milestones, determine if the age at which the older boys reach clinical milestones affect the prognosis of the younger brother. And this has also been submitted for publication, and we are seeing that there is some preliminary evidence that there is some concordance in the disease progression. You'll also see relatively soon a publication looking at the profile of pulmonary care received by the boys with Becker-Duchenne dystrophy. We've documented the types of pulmonary care received by the boys, and trying to look at the examine the changes in pulmonary care over time. As I showed you a while ago, at least in the Colorado data, over 80% of the boys have a cost assist, and a very high incidence are now using non-invasive ventilation for management. And so again, this will be data that looks specifically at the whole network and looking specifically at what's happening. So there are a number of manuscripts that are nearing completion. The population-based prevalence rates, and as we've already talked about, the prevalence rates are between 1.3 and 1.8 per 10,000. There's a number of there's some investigators looking at the prevalence and factors associated with some of the neuropsychiatric disorders that are also present. We're looking at the survival of the boys born during the age group between 1982 and 2001, and you can see it's significantly increased as part of that. There's a group investigating and looking at the medical and rehabilitation therapy services, and there's also a group looking at the health-related needs of patients and families affected by Becker-Duchenne muscular dystrophy. So I talked a little bit fast. I gave this to kind of give you a little idea of what specifically has happened with MD STARnet. You can see we've included a number of the publications on this next few slides. I'm happy to take any questions, and if we don't have the answer, then the MD STARnet group would be happy to go and look at our data and provide you with the information that we have. This is my address, and you can see, and then this is the website for the Centers for Disease Control, looking at specifically articles that have been published.
Dennis, I think another question just came in. I don't know if you can see that about the prevalence.
So Ivy's question was, the stated prevalence is 1 in 3,500. The data that we see, it was actually published. Let me go. It was published. You can see the bottom monograph there. Center for Disease Control. The prevalence was reported, and it varies, like I said, between 1.3 and 1.5 or 1.8. So we think it's a much more accurate reflection of the diagnosis or the prevalence.
And Dennis, how long will MD STARnet be collecting data? Is this something you'll continue for several years? Or?
So the data will continue to be collected. We're in the process now of creating a public database so that other investigators will be able to apply to the Centers for Disease Control to look at this particular data. It'll be a public domain, and so they'll be able to look at it. We're continuing this year. They've added 7 additional diseases, muscular dystrophies, and so we're doing a single prevalence look at that particular population, and then I think the abstraction continues, I think, till 2015, but I'll have to ask my friends from the CDC if that's the right number.
Okay, thank you.
So there's a question from Jennifer about physical therapy treatments. We are looking at the physical therapy treatments, and I've referenced that a little bit. There's a group now particularly looking at the therapies and rehabilitation needs. It's being led by the group from New York, and I think even this week they're presenting at the Academy of Neurology a poster presentation on that, and so there will be some presentation of physical therapy treatment and frequency. As you might guess, it varies by state. One of the nice parts of being a part of MD STARnet is you can see geographically each state presents a unique opportunity from a service delivery standpoint. We have very rural states and very highly dense and populated states, and so again gives us some variation. But initially we're struck with the fact that there is a very high clinic-to-clinic variation of an area-to-area variation in provision of therapy services.
Dennis, there was also a question about if there were any theories on why the incidence varied so much state by state. I don't know if you have any thoughts on that.
We're not exactly sure. We've tried to look at and see if there's ethnic or socioeconomic reasons, and there doesn't seem to be anything that lends itself to a true explanation. We don't think it's ethnic, and we also don't think it's, at least at this point, socioeconomic. So again, they're trying to look at specifically, and this is, as a clinician, this is when it's getting into those statistical things that I'm so glad we have the epidemiologists involved, because it's way beyond my expertise.
Right.
So Ivy's suggesting selective migration of unknown carriers. We certainly do. That was one of the challenging things is that there is a very high population of movement through and between states. So it was quite interesting to see the number of our patients who move from state to state and in and out of the state multiple times. And so as you realize, this was we think we corrected that a little bit by looking at the number of years that we did, but certainly there is that possibility.
Okay. And Dennis, I did have a question regarding the reproductive patterns article. I've not seen that article yet, but I was wondering if you'll continue to collect data on all the subsequent births to mothers of affected sons. And if so, I was wondering if anyone was planning to look at the incidence of germline mosaicism in that population.
That's been discussed. I guess my hope would be that yes, we would continue to survey and follow that population and actually do more specific testing and evaluation, but it's only been a topic of conversation and not within the scope of this particular project.
Right. Great. Thank you.
Kathy wants to know about transition issues. Kathy, it's being really analyzed just now. We as you or may not know, all this data gets de-identified and uploaded into a pooled database, and then we have to go through and evaluate it. And so, except for the information that I gave you from Colorado, I'm not able to give you a lot of information about the pooled database, but I would expect that to come out in this next round of publications within the next few months.
Dennis, I did have one other question as well. I didn't know if you could discuss any future research topics, and also if others in the community could suggest research topics, and if so, who they would contact for that?
Well, there's a tremendous number of research topics and issues that are being looked at. In addition to those that I've talked about, just trying to think. If people do have research ideas, they certainly could contact the Centers for Disease Control and see, and then they certainly can contact the MD STARnet, any of the people in the MD STARnet sites, and we would be happy to have a conversation with them.
Okay.
The limitation in some of the research design is the data has already been collected and uploaded, and so sometimes we're finding that we aren't able to manipulate or get the specific data that people want. We tried to think of the 800 or so data elements that most people wanted, but sometimes it's not available, or especially in the medical record. That's why we've supplemented it quite frequently with some interviews, but I think people will be more than happy to have a conversation.
Okay, great. We've had another question come in about the prevalence of Duchenne versus Becker's.
Yeah. So this has been a highly discussed conversation within our group. As you may or may not know, it's been very difficult to decide when the boys have Becker's versus Duchenne, except on, at least at this point, on clinical. So there is a group actually looking at to try and determine whether there's a group that we're calling later onset symptoms, or more consistent with the boys with Becker's. But again, it's been somewhat difficult to develop what we all agree to as a definition, and so it's been we've not been able to tease out specifically, at least from a prevalence standpoint, the Duchenne versus Becker's. But in some of the clinical programming and some of the clinical publications, you'll find that we are attempting to try and separate those two populations. Again, it's always this article is this a spectrum disorder, and so it would be nice if there were different gene tests, but there are no gene tests to specifically differentiate. So, we certainly will be able to do it based on some of the clinical activities.
Okay.
Question about corticosteroids. Yeah, we do have lots of data on boys with and without corticosteroids. We have lots of data looking at some variation. The difficulty with this kind of retrospective evaluation thing is that there's lots of variation within the clinics, lots of variation even within the individual patient stuff. So frequently where boys start, stop, change, the frequency of dosing changes, and so it's been a little bit difficult to control for all of those. But we are trying to look at, and the group from New York that's looking at the next set of data on oral corticosteroids are trying to tease this out a little bit. But there's so much clinic and or individual variation that it's difficult to get enough pooled data.
Okay. I think we have a few more minutes if anyone else has a question they would like to send in. while we're waiting, I did just want to mention one important point, and that is if you are interested in helping to advance research like this, please consider registering yourself or your child on Duchenne Connect. And if you're already registered, please update your information. Because like MD STARnet, researchers are using the Duchenne Connect data to improve clinical care for Duchenne and also to design better clinical trials and define treatments for Duchenne. And even if you don't want your child to participate in a clinical trial, registering on Duchenne Connect is still a great way and a very easy way to help speed research. And for those of you who don't know, the website for Duchenne Connect is duchenneconnect.org. I don't see any other questions coming in.
So again, on behalf of the MD STARnet group, I want to thank everybody for the opportunity to kind of present our information, and we would be happy to entertain any questions. You're welcome to communicate with us at any time, and again, I want to thank PPMD for its leadership in helping advance the research and knowledge about Duchenne muscular dystrophy.
Well, thank you, Dr. Matthews, for presenting today. We really appreciate your time, and thank you for everyone who is listening to the webinar today. And please join us next month. Thank you.